Sylvia is an associate professor in the Department of Medicine, Division of Allergy and Infectious Disease, an assistant professor in the Department of Global Health, and an adjunct assistant professor in the Department of Epidemiology. She is a ID physician who clinically focuses on HIV and TB issues, and in her research focuses on TB issues and HIV issues that pertain to women in pregnancy and pediatrics. She has a whole bunch of roles at the University of Washington. So she is the Global Women, Adolescent, and Child Health Scientific Lead. She is the Seattle TB Research Advancement Center, or CTRAC Development Core Co-Director. She's a faculty member for the Kenya Research and Training Center. And as you know, she's a faculty member on our TB Echo panel. I really appreciate Sylvia moderating this discussion. I think it's going to be great. Take it away, Sylvia.
Thank you so much, Bijan, for that kind introduction. I wanted to confirm that, am I sharing a slide? Great. So it's my pleasure today. We were doing something slightly different than we usually do for TB Echo, but it's my pleasure today to introduce Vidya Krishnan, who's an award-winning investigative journalist who's based in India, who's been reporting on medical science for the last 28 years, including the global right to health movements. She's received an International Reporting Fellowship in 2015 to report on the changing patent laws in South Africa and their impact on drug prices in African nations, and as a recipient of the prestigious Nieman Fellowship at Harvard University in 2021 for journalism. She's written for The Atlantic, the LA Times, and The Hindu as their health and science editor, and for the British Medical Journal. So I'm thrilled to have her join our TB Echo today to discuss her published book, Phantom Plague: How Tuberculosis Shaped History. I have one more slide that I want to show you. There are two more events that you can interact with Vidya Krishnan at. One is happening tomorrow at the University Bookstore, and you can see the QRS code there. These are both free events, but you need to register. And then on Thursday, Vidya will be giving a talk at the Hans Ronsley Center as part of the Department of Global Health. I hear that there's actually a waiting list for that now, so lucky for those of you who have already registered. So without further ado, I'd like to introduce Vidya Krishnan. Hi, Vidya.
Hi, thank you for having me. This is yeah, I'm on mute. I just realized. I am excited to be here, and we've been talking about this conversation for so long. So this is I'm so glad for the space that you have made for the book and engaged with the conversation that it was trying to force, I guess. I'm looking forward to this chat.
Great, thank you. So you describe your book as beginning both in the time of magical thinking before science and ending in a period of medical apartheid and science denialism. And I particularly appreciated how you included gender, systemic and structural racism and classism throughout, as well as literary examples to really provide a context to this phantom plague of TB and how it's shaped our history. My first sort of conversation starter is I really enjoyed how you weave literature with the history of TB, giving examples from Dracula to Sherlock Holmes. And I was wondering if you could talk a little bit about the parallels of Dracula and these magical beliefs regarding TB, death, and the undead that you found in your research.
Yeah, it was so weird. I started writing this book 7-8 years ago, but then when the last portions of the book were being edited, we were in lockdown because of this pandemic that we were in the middle of. And I was listening to, in my country, the political leaders were saying that you can do yoga or drink cow urine shots as prophylaxis against COVID-19. And I was writing at that point about magical thinking at a different point. In the US, I remember the Trump administration, I remember this press conference where he was talking about injecting disinfectant. And as a writer, I turned to history to make sense of how we behave. And throughout history, in research for this book, I started reading from the Justinian plague of the 5th century. And you know, throughout history, we behave so predictably in small-minded ways when we are confronted with pandemics. And which is why for me to start with magical thinking and get in Dracula, it was really nice to get Dracula in, because I like walking around claiming Dracula to be a public health infectious disease story. But it was nice. It was my open sesame for a difficult conversation. Uh, if you notice the book, in the first half, it's all pop culture and there's Dracula and fashion, because this is a very difficult conversation to have about tuberculosis and about our own biases that mostly lets it spread. So I thought the conversation would go down easy if we started with talking about how seeped into our history and our reflexes it is to, react with anger and fear when we are facing plagues.
Thank you so much. So sort of transitioning from our historical plagues to our current ones, one part of your book that was just so vivid to me is you vividly described this striking example of Building 10 in Mumbai, which was a site of a large MDR outbreak in high-density public housing, described as a vertical slum, as well as this trigger photo, which in part was used to identify the cluster. I'm hoping that you can discuss a little bit. Can you describe this example and perhaps how it exemplifies this perfect storm of poverty, poor public housing planning, and the spread of infectious diseases?
Yeah, thank you for that question. So, Mumbai is a global hotspot for drug-resistant tuberculosis. A lot like how KwaZulu-Natal in South Africa was the nerve center of the HIV epidemic. The only difference is most people in Mumbai do not know how dangerous the situation is. And in Mumbai, within Mumbai as well, it's a mega city. And I focus on Mumbai, but what's happening there is true for New York. Last week, I was reading about how there are more TB cases in New York now. And every mega city has this problem where we have this poor housing, subpar, subhuman housing for lower caste minorities. And once you do that, we basically ghettoize minorities in such a way that historically, this is true for syphilis and smallpox and many diseases where we know that infectious diseases boomerang in a slum cluster, maybe for a little bit, but they eventually ricochet out, as we saw with Wuhan. And in building number 10, which is in Mumbai East Ward, which within Mumbai also is the highest density of slums. So 72% of Mumbai's East Ward population lives in slums. And we have a situation where, Bollywood has done, we made movies like Slumdog Millionaire, where we show poverty itself in this romanticized way, where we talk of, there is this talk of getting to New York or getting to all these big cities, and how the subpar living is somehow some sort of an obstacle course in your personal rags to riches story. And in that kind of conversation, what you essentially gloss over is that these cities are in a very calculated way, designed in such a manner that the poor are subjected to a different kind of living. So building number 10 is one of these places where there are 51 people in the same building with drug-resistant TB. And it's like someone with rare cancer, just all neighbors. And this is something alarming even for Mumbai, even for India. But we just live in a place where our eyes seem to adjust to all sorts of injustices. And I speak to a doctor who runs a DOTS clinic in those slums, who compared what's happening in Mumbai slums to, he called it a Nazi ghetto. And that's actually the reality of life for someone who's lower caste or a minority in my country, which is actually not very different from what's happening in the US, where minorities have different mortality rates. We saw it with COVID, and we even see it with maternal mortality in African American women. These are the same conversation. With this book, I've tried to have it by centering TB. But with infectious diseases, these are not biomedical problems, these are social problems. And building number 10 exemplifies how housing contributes to infectious diseases.
Thank you so much. A different topic that I learned so much from your book was about intellectual property rights and patent law. And I was wondering if you can discuss a little bit about the role of patent law from your perspective in your research for this book, how it's potentially sometimes been a barrier to providing TB treatment to those who are most likely to need life-saving TB drugs and perhaps are the least likely to afford them, and maybe even perhaps using a Dilamidid or bedaquiline as examples.
Yeah, thank you for that again. So when this book essentially came to me, I was the health editor, science editor for The Hindu at that point, and I was covering this court case where a teenage kid had to take the government of India to court, Delhi High Court, to access bedaquiline at that point. And India calls itself the pharmacy of the world. And that's actually everything in that book, is to be able to tell the story of this teenage kid who currently does not have, who lives in the part of the world which has the highest burden for tuberculosis. There are medicines which Indian pharmaceutical companies were manufacturing in Indian factories for Johnson & Johnson, which holds the patent. It's an American pharmaceutical firm. So we have this bizarre medical dystopia. It's like globalized world where the medicines are being made in a fraction of a cost in an Indian factory, but Indian patients don't have access to it. And to be able to tell the story better, I had to talk about patents, which is essentially, we saw this with COVID as well. Drugs and diagnostics and tests and vaccines are, before anything else, technology. And before they are medicine, they are technology. And they're governed in this way where they are, intellectual property. There is this conversation about how intellectual property, especially in the West, is the bedrock of how the Western civilization has developed. It is so necessary to fuel innovation. And with science, it's really, really important to put that in context with race from my perspective, because not a single medical advancement has been made without experimentation on Black and brown bodies. With bedaquiline, the test, bedaquiline, in fact, is a perfect case. It's a case of genuine public funding. NIH funded initial research. MSF and the government of South Africa allowed for clinical trials to be scaled up and done in phase 3 clinical trials were done on TB patients in high burden countries. And the minute the drug was safe to get to market, TB patients in the worst affected parts of the world did not have access to it. And we saw this again with COVID-19, where the vaccines were developed, and we are now discussing it. I was in New York for the UNHLM on tuberculosis, where they were also discussing the pandemic treaty. And we are again having the same conversation after the pandemic. After 7 million people have died of COVID-19, we are now talking about not how we could have saved more people, but how we can save patents during the next pandemic. And the pandemic treaty right now has a clause which says that it should be legally binding on the developing nations to share genome sequences as viral outbreaks are reported, but it is not legally binding on Western nations to develop vaccines that are built on the same genome sequences that they want to be shared urgently. So, it's just increasingly become impossible to talk about how these patent laws were developed during a colonial time. The TRIPS law at its core is racist and unjust, because it was developed at a time with a single purpose: to allow the empires to basically excavate colonies. And this 21st version of that law, of intellectual property law, does exactly the same thing. It hollows out countries like India and South Africa. And we are now in a situation where Black and brown people have this bizarre half-life where they are necessary as data, but completely expendable as human beings. And that's what the portion on the that's what I talk about. Yeah.
Thank you so much, Vidya. I wanted to turn it to the perspective of the people who are living with TB. And throughout your book, you have provided examples of people with TB, including some that ultimately die from this disease, many of whom, at least in the examples that you describe, are amongst young women. And I was wondering if you'd like to share one of these stories and maybe how the role of the public policy of rationing of medications played into their ultimate outcome.
Yeah, you know, any kind of rationing of medicine, this is what sadly many of the people I were reporting on, many of my friends in the TB community died while this book was being written. And one of the last interviews I did was with Dr. Paul Farmer, who also unfortunately died before the book came out. And he spoke a lot about socialization of scarcity. And that's exactly what happened with bedaquiline. That's exactly why that teenage kid had to go to an Indian court to access bedaquiline, because we have created this bizarre you know, falsity of a conversation. It's like a boxing ring where in the right corner there is access to medicine and TB patients, and in the left corner is everything that's held, you know, free market and capitalism. And somehow, you know, how healthcare is a limited pie, and if you, as if it's a zero-sum conversation where if the patients get something, you know, someone else loses something. And this kind of framing is so dangerous. And the book focuses, most of the protagonists in the book are young women, teenage women mostly, who've had to face again, TB is also a gendered disease in India. Men in Mumbai, at the end, they, you know, even if they are low caste or in the lower economic quintile, they step out. And if you're an auto rickshaw driver or a lift operator, you live in a city by the Arabian Sea, and you step out and you're driving your auto rickshaw, but your wife is at home in that matchbox size house without ventilation. So it makes women more prone to contracting TB. Then there is stigmatization. In India, there is a belief that if you get TB, you cannot become pregnant. So many families send these women back. And then comes the stigmatization that you see at the facility level, at hospitals, where doctors have to play God and decide who gets to live and who gets to die, because you have to make impossible choices of is your life worth because you have a kid? And these are all things, the ethical conversation that doctors had during the early years of the HIV. And I guess pandemic after pandemic, we keep seeing, you know, in a very calculated way, the injustice of it falls on race, caste, and gender minorities. And we keep repeating these mistakes. And this book, again, kind of centers the conversation on the experience of a lower caste teenage brown girl. And these are, I believe, as a storyteller, I'm biased, but I have to believe that you can't defeat a good story. You can't send a tank after a good story. And these are stories that are coming out in the same way, you know, post-HIV plagues have to face these intellectual property laws. So this book is kind of an attempt to see where, you know, the interplay of everything is, you know, where the rubber meets the road, which is policy and history and racial bias. And I hope I've been able to do that.
I wanted to encourage, I have a few more questions for Vidya, but I really want to encourage the audience, you know, this is your time as well. I'd love to get other people's perspectives on questions. So please feel free to put questions in the chat for Vidya. My next question is, you and others have critiqued the sometimes outsized role of large philanthropic organizations, including the Bill and Melinda Gates Foundation, in shaping the global public health agenda and its response. And I'm wondering, from your perspective, can you discuss the role of these organizations, how they potentially help or hinder global health response?
Yeah, thank you for that question. I personally do not think that the right to health movement is the civil rights issue of the 21st century. It simply is, and we can have these conversations in silos of cancer patients trying to fight a battle to access trastuzumab, or TB patients trying to access delamanid and bedaquiline, or we can zoom out and look at this as one picture. And at its core, the basis of the global health insecurity, we are at a historic moment of vulnerability in global health. And one of the critical points of why people in post-colonial nations don't have access to new science is because of this because of this attitude that's very unique to the West, where they assume everything is intellectual property and they're right before anyone else. And what organized philanthropy does is legitimize this structure, because charity will never be the solution for something that's a right, which is a fight between me and my government. Universal taxpayer fund, universal healthcare is the only solution. That's the only way we turned the tide on the HIV epidemic. That's the only reason why polio was contained, because polio vaccine got to the people at point of care. And if we keep trying to outsource and get somehow a subsidized healthcare, which is an NGOized commodity, it will never truly become. It will never. I'd like to quote. There is this quote by Achebe, Chinua Achebe, who was this Nigerian poet and author, who said that charity is the opium of the rich. And that's exactly what the problem with the Gates Foundation kind of philanthropy is. In fact, during the second wave, India had a devastating second wave, and we saw bodies floating in our mythical rivers in Ganga, where there were communities who our crematoriums had run out of places, and people were just leaving their dead loved ones in the river. And this was happening in Uttar Pradesh, which is one of the biggest laboratories of the Gates Foundation. In fact, health reporters in India for decades have called Uttar Pradesh, we call it the graveyard of the pilots. That's where all the pilot projects go to die. It's a lot of money. You throw money at it and you find data to say what you've already decided that you want to say. And when the second wave was happening, and of course it's a problem with the regional government, of course we must, Indian journalists question the regional government. But as a global health reporter, I do want to ask the question, where has the billions of dollars gone over the last 2 decades that went into health system strengthening in Uttar Pradesh? Where is all that money? It's a question that we get to ask the Gates Foundation, because I've over and over again, after the second wave got over, we had, especially in North India, we have a right-wing government that jailed people who criticized the government response and attacked minorities and Indian Muslims for the same way as Jews were accused of spreading typhus in Nazi Germany. And after all of this, after people were jailed, we saw Melinda Gates come in December 2022 to Uttar Pradesh and tell the regional government that the response was commendable and an example for the world, with the confidence of someone who will just never have to live in UP and face the consequences. And these kind of ethical standards that global organized philanthropy has, where you'll not see Melinda Gates stand next to Alex Jones, but she comes to my country and does that. And that's not okay.
Thank you, Vidya. And again, I want to encourage people to either make comments or ask questions. One thing that your book made me think about is the role of kind of along the same question, the role of the potential detrimental role of medication donation and using tiered pricing that can affect TB drug supply and functioning TB public health systems. You know what? I see that Bijan has his hand up, and so I'm going to pause here and let Bijan ask a question.
Well, I just wanted to follow up on what you were saying, Vidya, about, many people on this call here work in public health departments in the United States. And we all, I think, believe in the public health model and how important it is against TB, which is a persistent and patient entity that requires a whole bunch of different people working in a lot of different ways to get patients through treatment and following them up, all that sort of thing. And what I'm hearing from you is that the sort of subsidized NGO model doesn't work. And when I read your book, a lot of the things that I was wondering about is, well, where is the public health infrastructure in India? And what do you see as the solution to that? Because I think that is, when I compare what I understand about TB here in the United States, what I read about in your book, that was the biggest piece that I saw missing, is
Yeah,
public health infrastructure.
Thank you for that question. This is such a layered problem, which is true for many post-colonial nations. India actually is one of the better countries. The problem with India is that it's not one of those countries where you don't have a medical expertise. Indian doctors are actually famous around the world, and India exports a lot of its doctors and nurses around the world, including to this country. And it's a country that contained polio. It's a country which is very familiar and has like deep logistical infrastructure to do mass vaccination campaigns. We've done it for leprosy and we've done it for polio. What's happened now? What's happened in 1991, India was liberalized, which means our economy was opened. And in 2005, India became TRIPS compliant, which means intellectual properties went into force. Essentially, what's happened now, why India cannot do these vast logistical campaigns for something like TB, is because the latest drugs are under patent monopoly. So it's actually not true that we don't have the health system. We actually are in a state of regulatory capture, which is partly because of the right-wing government in India, which does believe that Eastern medicine is superior than Western medicine. So there's a whole lot of that right-wing thing, which actually is not an India-only problem. We see a global swing towards right, And then there is a second layer of problem where we also are the pharmacy of the world. So what that has happened post 1990s is that Indian generic medicines turned the tide on the HIV epidemic. At $1 a day, Indian companies like Cipla were supplying to JCRC in Uganda and to MSF to make sure antiretrovirals got to Africa, where the worst of the burden was. What's happened since is big pharma and big philanthropy in particular have learned their lessons. And the way I see it is Indian pharmaceutical companies like Cipla, which in the 90s got cheaper generics to the poorest countries, now just signed voluntary licenses with big pharma. So we have gone from being the pharmacy of the world to the contract manufacturer for big pharmaceutical companies. So we are making the drugs at fraction of the cost, but still continuing to supply to Pfizer, which is what happened during COVID. We were in a duopoly because how WHO, and again, Gates Foundation was critical to Covaxin, where, Covax was an Indian company called Serum Institute had to make the AstraZeneca vaccine, which came out of the Oxford University. So it was a taxpayer-funded vaccine, which, because of Gates Foundation's central role in how the vaccine was distributed, got caught in a duopoly, and one Indian company was manufacturing it for the whole world. So India had this bizarre responsibility to produce vaccine for the country with the largest population in the world, but also to 92 other countries and supply to WHO. And that's how the pandemic, this is a long-winded response. But I guess what I want to say to you is that the problem that we see in post-colonial nations now is actually, it's unfair to blame only the regional governments. Of course, the investments in public health is less in India, and that makes the public infrastructure weaker. But the global economic order, actually, we have to have that conversation first before the regional conversation. Because why is the WTO during the entire pandemic, the WTO had a central role and not the WHO. We have a global economic order where we had to go to WTO to talk about the COVID waiver on vaccines for the pandemic. And I personally think that it's at another panel, someone was like, many of these countries where COVAX did get vaccines in time, there was anti-vax movements there, like in South Sudan and even in India. So of course there is anti-vaccination, but you have anti-vax movements in the US as well. But that's never used as a reason to not have a vaccination available at Walgreens or CVS. And if you did not have a CVS or Walgreens getting you those doses free of cost at point of care, you will see the same problems in the US or in Paris and in Canada and all of these places as well. I don't know if I'm rambling at this point, but that's kind of, I feel like it's unfair to criticize India in isolation, without getting the role of WTO in it.
Oh, I'm sorry. I certainly didn't mean it as a criticism. I wondered if all
Yeah,
that money that
yeah,
you said was funneled in one way could have been used in a different way, I guess is what
yeah,
I was getting. I see that
yeah.
Teresa has a question. I'm sorry, go ahead. Teresa, do you want to unmute and ask your question?
Sure thing. So thank you so much for so far. I want you to keep going for the next 5 hours. I'm curious about your thoughts on the Global Fund to Fight AIDS, TB, and Malaria, since that's a global partnership that does bring multifaceted folks together, and looking at that type of leverage. So I'm just curious of what you have found with that. And I'm still waiting on my book. So thanks.
Thank you for picking up the book. And thank you for this question. The Global Fund actually was a great example of how I'm a fan of portions of Global Fund, because what happened, the GFATM came together in a real way in 2002, and then we did it. It has so many solutions built into it, but I feel like I don't want to say that we don't learn our lessons from history. I want to say we only learn the wrong lessons, because with GFATM, we did three things very well. One is the kitty was central, and we prioritize on the three biggest threats to global health security, which is HIV, TB, and malaria. And then we also set up the pre-qualification program to make sure that there were quality drugs, which people could rely on without like these kind of, just before the start of this session, there was a conversation about drug availability. And the GFATM with PQPs not only made sure that there was money, but it did the dirty, boring plumbing, made sure that the foundation worked, the logistical supply chain worked. In every part of the world, the GFATM's pre-qualification program became a de facto drug regulator for countries which did not have drug regulators to qualify the quality of antiretrovirals. But then we stopped short. Since then, I don't see why. I don't know if you guys are following this story that's developing in Gambia with Indian drugs that are substandard cough syrups that are killing kids in Gambia and Ukraine and many of these places. And what's essentially happened is, at this point, the program like PQP is entirely voluntary funded. WHO had to make it available for a for-fee model, which of course poor countries don't have the money for. And then we have this bizarre, again, regulatory inequity in post-colonial nations. So you have US FDA and EMA, which flies in their inspectors to countries like India. In fact, US FDA has the highest number of factories that are manufacturing for US, but in India at a fraction of a cost. And US FDA's drug inspectors come and visit it. But of course, Gambia cannot fly out their drug inspectors for every program. So India then, again, this is the issue with the free market organization of global health. So your question was about tiered pricing earlier, and all of this comes in because Global Fund, something like Global Fund, has fallen short of its vision. Instead of expanding it over time beyond, like, we got a proof of concept, we know that it works well, then why are we leaving a situation where countries like Gambia have to fight so the Gambian parliament is now suing the Indian government and the manufacturer, and these two post-colonial unequal countries are fighting each other out because the global health structures are failing, and they seem to work in a way where they ensure the safety and the standards for global north without kind of extending it in a good faith for developing nations. I don't know if it answers your question well. It's that thing about benign parenting. You have to go beyond what's asked, because this is reparations.
Thank you, Vidhi. I wanted to see if there were any questions or comments from the audience. This is your time, and I'd love to encourage any interaction. If not, I'm going to ask a question about the role of a journalist. But let's see. Does anybody have a hand up or a question or comment?
I don't see any yet.
I would love to talk about the role of please ask me that question.
Excellent. So, most of the people here on this call, public health practitioners, clinicians, etc. And I don't, unless I'm unaware, I don't think there is another journalist as part of this group. And so I'm very curious as to what you think, to hear your thoughts on the role of being a journalist in sort of the face of science denialism and things like that. Currently, so I'd like to hear your thoughts on that.
Yeah, when the book came out, I was described. I was described by many reviewers as a journalist who wrote a book about TB, and since then I've been called a TB advocate, and I am a writer who writes about social justice at a time where mostly around the world the deck is just stacked against the poor and the vulnerable and the sick. And within global health, there is just so much information asymmetry, because the conversation is just, you cannot have a fair conversation with a doctor because the doctor just knows more about what you need. And, when you're sick and you're unsafe, you go to a health system hoping that it'll care for you. And both in this country and my country, we have this two-tiered system. In my country, it works on caste, and in this country, race is where, is what the dime spins on. And I feel like, again, we talk about how HIV is such a successful public health movement, and the only difference between something like the HIV movement and the global tuberculosis movement is that they have patient survivors have been struggling to get their stories out for a very long time. But I see now, even in the last 5 years that I was working on my book, that's changed. During the UNHLM week, there was an author panel where there were 3 female authors who've written 3 new books about tuberculosis, and it's changing. We now see Nandita Venkatesan and Fumeza, who's these 2 Indian and South African tuberculosis patients who challenged the American pharmaceutical firm in an Indian patent court successfully. So the advocacy movements are coming together, but I do feel that storytelling is a very important vehicle, which this particular advocacy movement has not used as much as or as successfully as the HIV networks did. But again, the HIV networks in the US in particular that had many advantages where it was happening to white gay men in New York as against, a lower caste brown woman in like in an armpit in a village in India. So there are those kind of things, but I do believe that you can't defeat good stories.
Thank you. It looks like there's a question from Monica Pekka.
Okay. So I guess my question is, you've talked a lot about and really shined a great light on all of these, issues that we have, what's been wrong with some of the larger systems, larger philanthropy. but us as individual kind of US public health workers, what can we do, I guess, to better support besides the work that we do now in our individual communities?
Thank you for that question. In fact, I do believe American taxpayers have a particular role that is more important. It's curious. I'm thinking as I answer you, because I believe Indian taxpayers also have a unique role, because India is the pharmacy of the world. India has the world's largest generic pharmaceutical company. So India has this unique responsibility to manufacture for itself, but also has the manufacturing capacity to supply for others. But the same way, American taxpayers have a very unique role, because their taxpayer dollars, this is the money that funds most of the R&D that eventually ends up, this is public research that ends up in private monopolies. And I now see, and these are all American corporations. During the pandemic, Pfizer and Moderna were demanding that post-colonial nations, if they wanted access to the mRNA vaccines, had to pledge their national monuments as collateral. And exactly these kind of conversations where you bridge the gap between what is being done in the name of American taxpayers by American institutions. I know for a fact, I have friends in advocacy groups, and I have friends in the academic community as well as the advocacy community who are Americans and who do not stand for this. Yesterday, I was watching the protests outside White House against demanding that the Biden administration advocate for a ceasefire. So it's such a big role that can be played here, especially in places like Seattle and Geneva, where all the decisions of global health are made, and the consequences of this have ripple effects in, there's a domino effect in every post-colonial nation, and those voices cannot be heard. But I am more optimistic now. I am, even 5 years ago, I cannot imagine something like this, like a book like this or an author like this having a conversation like this in a place like this. So there is reason for hope.
I see Bajan's hand, and then I also know that Jennifer Saragardi has a question as well. Go ahead.
I just wanted to piggyback on that about the taxpayer dollars going to R&D and then it becoming a private issue. Do you see any improvement with the model for Protominid by TB Alliance? Do you see that is what do you think of that?
Oh, frankly, between new model, I am very hopeful right now. I'm more hopeful right now than I've ever been, because the news, when I was reporting in the ghettos of Mumbai, there were people who would constantly tell me that we cannot wear a face mask because, even in a very crowded slum, in a very crowded part of the world, wearing a face mask is stigmatizing, and you can be very alone without friends. So in 2023, 3 years into a respiratory pandemic, we are at a point where around the world there is more acceptance for masks. There is more acceptance for actually vaccination. There is more knowledge about things like RT-PCR, and which has become colloquial words, which were just a very limited to the infectious disease world even 3 years ago. In my country, there are more molecular testing devices, there's more diagnostic, and there's more testing available. So we, as far as infrastructure is concerned, are at a better place than we've ever been. I personally feel that more than the shorter regimen of TB, which is a huge help and should be very quickly scaled up, because there's no reason why patients should be maimed with a 2-year treatment when there is a 6-month treatment. My hope actually is on the vaccine. I don't know if you followed the ProPublica investigation last week, where they said that GSK has been sitting on a TB vaccine since 2018, only because it's not profitable. It's a vaccine that works perfectly well. And Treatment Alliance, TAG, already came out with a statement. Again, it's an NIH-funded vaccine that's just been sitting on a shelf because GSK felt that it will not be as profitable because all the high-burden countries are not commercially viable markets, which means they don't pay in dollars. They pay in rupees or takas, or, the currency is not the same. And my hope actually is with the TB vaccine, and everywhere I speak, I call for an urgent acceleration. That vaccine belongs in public, and there is no reason why people should be allowed to die from TB when a vaccine is sitting on the shelf. I know I did not answer about Protominate, but I feel like that vaccine we should talk. Like, I did not know you could do something like that. I did not know you could have a vaccine and you could just shelve it while millions of people are dying. And again, the fact that a British pharmaceutical company is sitting on a vaccine that kills people in India and most post-colonial countries, it's just the optics of it. And I want to talk about that before I want to talk about Protominate.
This is a great.
I'm glad you
segue.
did, because I had not heard of that at all. So I plan to look into that. And Sylvia just put the link there. Thank you, Sylvia.
Yeah.
Carolina has a question.
Oh, actually, first Jennifer.
Oh, I'm sorry.
That was my question. I just wanted to hear your thoughts on the TB vaccine. So thank you.
I do hope that, in most of these conversations, I was with at NYU Wagner with John Green and his nerd fighters, and that's like a very new way of doing advocacy within the TB community. And I feel like if the community came together, it's just shocking and appalling and violent to allow people in Black and brown nations to die when a taxpayer-funded vaccine is sitting, and none of us should allow for it. None of us should stand for it.
And Carolina, she's a infectious disease doc at Seattle Children's. Go ahead.
Yeah, thanks, Lana. Actually at UW, but I do immunology research, as you can see behind me, at Seattle Children's Research Institute. So thank you, Vidya, so much for coming and for speaking with us. And I'm looking forward to your talk tomorrow as well. I wanted to ask kind of along the lines of what, what your current audience can do to contribute. I've long thought that the academic community has a pretty unique role to play in terms of ensuring access to the fruits of biomedical technologies, because a lot of the drug development is being funded by taxpayers, and then is being done by people in environments like this around me, by people who are not in it for the money, and so a lot of the initial work is done, and sometimes middle and increasingly even late phases is being done in academic environments. And it makes its way to the technology transfer offices and then to corporations, which do add significant value. However, they can be bound by contracts with the universities and other public institutions that generated key essential technologies. And so I wanted to ask you what you see, again, it's kind of a big question, but what you can see members of academia doing in order to promote access to the fruits of these biomedical research.
Yeah, thank you so much for that question. At this point, I feel with TB in particular, historically, it's had this problem where it's treated as a biomedical, like in isolation, as a biomedical problem, when infectious diseases are a social problem. So we have all of these laws that are made in Geneva and Seattle in these lab setting. And then the minute they are out of this lab setting in an imperfect environment in like a village in India, everything falls apart because there's no cold chain, or someone doesn't speak English, or someone just there's no electricity, and all sorts of these smaller things. Anyway, I speak, I tell whenever I have a scientific audience, I talk about the complete lack of love in scientific policy. There is almost, making it a virtue that, science is pure and in isolation. And I kind of look at that as someone who comes from a humanities background. And I feel like without including art and literature and poetry, science is without beauty. And that's what we have with the TB policy. The fact that something like DOTS could fly for 30 years DOTS is, according to me, one of the most spectacular failures of WHO. When it failed, when as early as late 90s, when in countries like India there were drug resistance emerging, the DOTS plus strategy recommended retreatment with the same cocktail which had failed. And DOTS is at the core how it's designed, where as against the HIV patient, where you're just handed a medicine and you're trusted to go home and take care of yourself. DOTS just places this bizarre, almost unkind demand on the patient that they have to turn up day after day after day at a building, get stigmatized, lose their job. And, the way I think is only a person without heart, without complete compassion can come up with a policy like that. Because on one hand, we have this TB policy, which, by the way, even the Sustainable Development Goals, I gave a lecture at UCSF where I said that the goals that were passed in 1991 as a part of as a part of a resolution at World Health Assembly were not achieved till 2015 in the Millennium Development Goals, which have also not been achieved, and that's been woven into the Sustainable Development Goals. And now we have a end TB target of 2030. And we have this bizarre moving line for policymakers where your target to, control TB keeps moving and moving and moving. And you have a policy that gives zero wiggle room to the patient, where they cannot skip, they cannot leave room to just vomit and, be sick and just stay in bed one day. They have to keep turning up. And I don't understand how someone could devise such a policy and not think about their own patients. And now we have this talk about, how patients are failing treatment, how patients are creating resistance, when the truth is, it's the academic community that's failed the patients. And I am seeing more activism from the academic community, and that fills my heart with joy. At McGill and at UCSF, and now here, I see so much activism that comes from the scholars, because that's the only way this information symmetry can be, unless academicians join patients, this information asymmetry will not be fixed. Thank you for that question.
I'd like to thank everybody for joining us today. And Vidya, thank you for talking with us about some of these really important themes throughout your book, including some really provocative statements that I think we all will think about. And again, I'd like to thank the TB Echo community for letting us try something a little bit different and new. Lana or Bijan, do you have anything you'd like to say in closing?
Only that I really appreciate you joining us, Vidya. I thought that was great. It is something new, and I think it was helpful for those of us working here in the U.S. on TB to understand the challenges globally that are being faced, and maybe we don't have it so bad, honestly. For those of you that are new, please do think about joining us on a weekly basis if you want to learn about the clinical care of TB and public health strategies for dealing with contact investigation, that sort of thing. That's what we talk about. We also have didactic lectures every week, so please do join. And do submit your cases, because we need cases to learn from. Vidya, thanks again.
Thank you for having me. Thank you for coming to this. Thank you for hearing me out.
Thank you all.
See you all next week.